many of you feel like you need to review your directive? About the same number. So it might have been a while since you last completed an advanced directive. And what I find with many of my clients is they might have done a directive but not put a lot of thought into it the first time. They may have gone into the doctor and had a quick counseling session on completing one, or found a directive form from their faith community or an attorney's office, but now they're really trying to evaluate, does this document meet my needs, and does it properly reflect my wishes? So today my goal is to make sure that you understand what the essential legal components of a healthcare directive is. So my perspective on this is going to look a little different than Deb's, right? So I'm an elder law attorney, and I deal with clients who are coming in for their estate planning all the time. Some of them might have chronic care needs as well, or encounter short-term or long-term disability. And we're trying to talk through what their advanced care planning components are and what they really need. But personally, I have only been designated as an agent on a client's document and a family member's. I've not had to activate my role, right? So I've been sitting in the wings trying to be prepared and get my own knowledge on how to do a great job in this capacity. Deb's experience will speak more to kind of what the role of an agent is and all of the duties and responsibilities and how to have productive conversations with them on that role. So I will also identify a couple of documents that you might want in your toolkit in addition to a healthcare directive. I'm not going to get into your essential estate planning documents like powers of attorney or wills. My focus will really be on care planning today. And then I want to give you a few tips for how to start having these conversations with your loved ones, because this is a big hurdle for many of my clients. I find that often in Minnesota, our default is that we'd like to stay upright and quiet about it until we die. We don't really want to get into the weeds of what life could look like for us if care needs present themselves. And then I want to give you a few tips on assembling a care team. This is a big priority of mine when I work with my clients. I think that we're all stronger when we have a team around us to work together that understands our values and our wishes and makes sure that those are carried out as we need them. And so I'll identify a few players that you might want to recognize or identify in your own planning. So I always really like this Rosalind Carter quote that talks about caregiving. So she says that there's 4 types of people in this world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who need caregivers. So we will all fall in one of these categories at some points in our lives, and we might end up in multiple situations involving caregiving. Now, when we talk about caregivers and ourselves potentially needing care, we really want to enable that care team or those caregivers to have the information they need to do a great job and to make sure your wishes are fulfilled and satisfied. The best tool to do that legally is through a healthcare directive or an advanced directive. So I give kind of similar reminders that if you've heard me talk at these events before, you might recognize them because I speak to them often. So make decisions early is your first reminder of the day. We want to do planning before the crisis, right? Crisis planning is not planning. It's a reaction, right? We've had a medical event and now we need to take action immediately. Or we might not be able to think clearly about what our wishes are because we're in the midst of trauma, okay? So ideally, if you're thinking, oh, my healthcare directive really needs to be updated, the time is now to do so. So I'm really happy you're all here because this tonight will give you the tools you need to think about those edits. And I encourage you that after tonight, you move forward with making those updates. It can always be modified as things in your life change, but we don't want to wait until the crisis to find out your wishes aren't accurate, okay? So the other thing that I really want you to do or think about is who are the point people, who are your trusted family members, loved ones, or professionals if something happens to you. And finally, kind of my motto with all of my clients is, you want to plan for the worst so you can live your best. In advanced care planning especially, we often talk about worst case scenarios, or what is your worst case scenario. It might be different for you than it is for me, than it is for your neighbor, right? So we need to talk through what your wishes are and what you want and don't want under certain circumstances. So healthcare directives, as I said, are the best tool we have to communicate our wishes with our loved ones and also with medical professionals and the legal community about who you want to act as your agent and what your wishes about care planning are. Now, healthcare directives have taken different names in the past, so some people recognize it or call it an advanced directive. Some people have called it a living will or a durable power of attorney for healthcare. So before 1998 in Minnesota, we called healthcare directives durable powers of attorney for healthcare and living wills. They were kind of two documents that supplemented each other. Since 2008, it's all under one form or one document. So that it's defined in Minnesota law to really cover and allow you to designate someone to speak for you if you're incapacitated. But you can also set it up to have someone appointed, even if you do have capacity, but you think you need a little support with healthcare decision making. The primary players in advanced care planning are the principal, that's you, the person who's signing the document, okay? Then we have agents, which are the people you've appointed to act as your legal agent to make medical decisions for you. And it could be one person or it could be multiple, okay? We want to talk through though and make sure the document's clear. If you have multiple people and they're disagreeing about a choice, whether they must act together or they may act independently. And we always want to think through when we're designating an agent or multiples, how will this work in practice? Do these people get along and are they on the same page and understanding of your values and wishes? And we can also designate a successor. So if your primary isn't available because they're unwilling or unable to act for some reason, who's the backup plan, okay? Now, healthcare directive forms can take many different forms, okay? So none are wrong. It's just what works best for you and is easiest for you to complete and meets your wishes, okay? Typically, a lot of my clients work with Honoring Choices of Minnesota. The Honoring Choices of Minnesota is a form that provides a short form, which is in essence a directive that nominates an agent and has very limited outlines about what your wishes are for that agent to do. And then a longer form which speaks more to your values and your wishes about types of care you would receive. Yes.
Can you just do a short form to get something? I don't have anything.
Right. So
just do a short form and then fill in the I don't knows later?
yes. So what the question was is, can you do a short form now to make sure you have something in place and then expand upon that through a longer form later when you've thought through all of your values and decisions? And the answer is yes. I think that the most important component of a healthcare directive to me is that legal designation of a healthcare agent. Why? Why is that the most important? So under the law, agents have the ability to speak for you and act on your behalf if you're incapacitated. That means they have a lot of power, okay? They're going to be able to say and listen and respond to medical professionals to make the decision that they feel is in your best interest. Now, ideally, we'd give them some guidance so they fully understand what your wishes are and why you've designated them, or perhaps more information about what quality of life means to you, that all makes the agent feel like very secure in making decisions for you. But we need, at a minimum, to designate an agent. Yes?
I'm just saying that the title, the honor and choices, really is a challenge to us to make our choices specific. And that doesn't know, if that's, that's given priority, I would think that would be ennobling of the people filling out, and each of us filling out the form.
Right. So some forms, what I'll repeat is that the audience participant mentioned that she wishes almost that the form would be more clear, that the priority or the focus is on designation of an agent if the rest is optional. And I think that each form varies on how it's set up. But for what we're communicating today is that the designation of an agent is a critical component. And if you can't identify an agent for yourself, we'll talk about some alternatives. If you don't have a family member or loved one to appoint and you want someone, you might need some outside resources to act as your agent, we'll walk through that. But each form is set up a little differently. Honoring choices will look different than the 5 wishes document. 5 wishes is a form that's set up to go through a series of options for you, or 5 wishes or areas that they feel are important to end-of-life decision-making and quality of life. And they have you circle components that resonate with you. They give you some language or options to utilize. Some of my clients like that, others do not. They want to put it in their own words. So it's really client dependent what works best. And the University of Minnesota Extension, that is also a free document. The state of Minnesota statutes has a free document. So there's lots of accessible resources for creating it. I do want to tell you that often my clients have printed all these forms out and they come into my office for estate planning and they've completed none. Okay, the forms have been left blank around their kitchen table. It's been on their to-do list for some time. So often when I'm working with clients in that circumstance, the goal is for us to complete a form, and we might utilize the form that my office has developed. None is necessarily better than another. We just want to make sure it's done. Okay, so if you or your loved one is over the age of 18, you need an advance directive. Okay.
I have a question. Where do you get those forms?
So,
online, but you have to register them, or is it just your private?
So where can you access forms? Forms can be accessed, these forms that have been referenced here, the University of Minnesota Extension, Honoring Choices, and 5 Wishes, are available online to be printed and downloaded, as well as the state of Minnesota statutory form. They can all be downloaded from the internet. 5 Wishes is for a nominal fee. I think it's under $5 per document that they charge for the form. Okay. Yes, I see lots of questions, and I might have to hold some so we can make sure we get through all the content. Yes, ma'am.
Do they all allow access to filling it out online?
So the question was, do all of them have an option for completing it online? And the answer is no. So most of these documents are PDFs or Word versions that will be printed. And the reason is that they will eventually need to be printed is because in order to have a valid healthcare directive, it must be signed and either notarized, or it must be signed and witnessed by 2 witnesses who are not named in the document and are over age 18. Yes, Sarah?
Because this is being recorded and it will be posted on the City of Roseville's website under the Dementia Information section, we will add to it a document that has links to the different forms and also some of the healthcare services that provide free assistance if you want to fill them out. So
Wonderful. So
next week, don't look for it right away.
Okay, for the recording, Sarah mentioned that the forms or links to forms that are downloadable will be available online on the Roseville Dementia site, and you can access that by going to the City of Roseville site and then searching through there. And those will be posted likely a week or so from today. So you can look there if you don't feel comfortable searching for these forms on your own, okay? So why do we need this document? Why is it so important? To me, one of the primary reasons that you should have this document is that it preserves your autonomy. It allows you to be the decision maker, even when you can't speak for yourself. So you're designating someone who can speak for you, that you trust, that you know understands your values and wishes, and that you can count on to make decisions for you when you can't speak for yourself. That allows you to exercise some control. Now, if you don't have an agent designated, if you don't have a directive, then we're caught trying to figure out who has legal authority. Okay, and if you're over 18, you have a authority to act for yourself, but no one else has legal authority to act on your behalf. Okay? And we don't know necessarily what your wishes are, what you would have wanted. We're left guessing, and that means medical providers are left guessing. And I can tell you that there's kind of a default within medicine now that their plan is to treat you, right? Their goal is to keep you upright and getting out of the hospital or the clinic without any issue. And they're going to do what they can to get you in that condition. So if you have said, your wish is to not have resuscitation, for example, if you do not want to be resuscitated, if you do not want to be intubated, then you're left as someone who might receive that treatment because they haven't clearly communicated in writing to a provider otherwise. Okay. Now, this guide, it also serves as a guide for those people that you've appointed, and we've touched on that a lot. I've talked and counseled with many family members who are becoming an agent, right? So their loved one has completed a directive, they might have completed some estate planning, and they're feeling lost now. They've been designated, but they've received no guidance for their loved one. They've never had a conversation with their parent or spouse about what they would have wanted. And now they're trying to grapple with, oh gosh, I really love this person. Maybe selfishly I want them to stay alive for a while, but I don't know if that's what their wish is. And they're trying to navigate through their fears about this person's recent condition and their own feelings about what might life look like at this point. And it's a lot to juggle all at once. Deb talks beautifully about this, so I'll let her speak to it more later. But we've talked about one critical component of a healthcare agent, and that's the designation of an agent. But we also want to include some directions to that agent for what your wishes are. And generally, we do want, one of the components can be a release, allowing your agent to access your medical records and health history with a provider. Now, in our documents, we always do this because I have had people who have been appointed. For example, I have a 40-something couple right now who the wife has had a stroke unexpectedly, is in the hospital, and the husband's trying to gather some information related to her care in the hospital and the stroke, trying to figure out what exactly happened, the cause, if there was something that was handled improperly by the healthcare professionals, and he's being told by the provider, we can't disclose this to you. You are not under the HIPAA rules or the Healthcare Privacy Acts, they're not allowed to disseminate that information to just anyone. So it's very important that we have a release found within your healthcare directive that authorizes an agent to access your medical records. I've also worked with clients. One of my clients is a sister of an individual with breast cancer, and she also wants to understand the type of breast cancer it was to know for her own genetic if it's possibility that this runs in the family. And because the document that she had did not allow her to access health information, it's been difficult for her to retrieve that. So I want to counsel you, that's something that people often don't think about, but could be critical if you needed care. You can also designate things like whether or not you would want intrusive mental health treatment. So if you have a history of mental illness, it may be important to enable an agent to make decisions regarding neuroleptic medication, antipsychotics, or electroconvulsive therapy, ECT. Okay, some people who have a history of that may want that, they may not want that. It could be made clear in your directive. Now, something that people often don't think about is that as there are more and more cases of dementia, often the treatment for dementia might involve some use of neuroleptic medication, which is medication that's typically used for conditions such as schizophrenia. Okay? And the reason being is that it helps monitor or calm an individual with dementia. And sometimes if the directive doesn't allow it, the agent can work with the doctor to ensure that's what you've been provided. So if we really trust the agent that you're appointing, we want to give them broad powers to make these sorts of decisions. You can also include things like, after your death, do you want to donate organs or anatomical gifts? You can also direct your wishes about a funeral or memorial. So you can provide an instruction to your loved one or agent to enable them to coordinate those things on your behalf. One thing that people don't think about is that technically right now, if you have 6 children, and you have not given one of them the power to coordinate your funeral and memorial wishes in a directive, they all have equal priority after you die and must agree as to what happens, be it burial or cremation. A funeral home will not do anything with your body unless they've gotten consent from all the immediate next of kin about that action. Now, if you have it in your healthcare directive that your agent can coordinate your funeral and burial decisions, and your agent can direct what to do from cremation or burial, then that one person can go ahead and make that decision rather than having a large party do that. You can include instructions about receipt of artificial nutrition and hydration, the use of feeding tubes, and at the end of your life, and really any wish you want regarding your care or what quality of life and values mean to you. So what if you don't have a directive? There's a few of you who didn't raise your hand that you had one. So if you don't have a directive, then we have really no clear path. We have no legal decision maker appointed. We know that the default in medicine is to treat. And if a loved one of yours or a healthcare provider feels like they do need a legal agent to make a determination, then the only way to proceed with that after you're incapacitated is through a guardianship proceeding. And guardianship is a court process in which we have to petition the court, the local court in your county, and indicate that you don't have a directive, there's no other option, and we need a legal decision maker in place because you are in need of someone to make these decisions on your behalf, but are no longer able to sign a directive. At that point, the court has to review who you've nominated or who is petitioning the court for guardianship to make sure that they feel like that is somebody who is able to handle those duties. There might be an argument among loved ones about who should act in this role. We handle those all the time, unfortunately. And then we have a third-party judge making a determination on what should be a private matter, right? It should be left to you to really direct your care needs. The other thing to note about guardianship is that it is an expensive and time-consuming process. Anytime we involve the court, that means that we're operating on the court's timeline and we have costs. Typically, people need legal representation and there's court filing fees. So in Ramsey County right now, if I petition the court for guardianship, it takes me about 8 weeks before I can get in front of a judge. In the interim, in those 8 weeks, what happens? There's no clear path, there's no legal agent, and default treatment is applied. I saw a question.
If the agent also has power of attorney, does that solve some of the problems as far as making decisions about funerals or medical record releases and that kind of thing?
So the question was, does a power of attorney help with things related to maybe conflicts or discussion about who has authority to make funeral or burial decisions, or who has access to medical records? And the answer is no. A power of attorney really handles some financial transactions. The document itself determines what those contain, and generally a power of attorney dies with a person, right? It's a living document. It only works while the person is alive, and if they're deceased, it has no bearing. And it does not have bearing over medical decisions and medical data releases.
If they're your personal representative in your will or your
So
trust document, then does that work?
the next question was related to, does a personal representative, executor, or trustee have that power to make funeral or memorial decisions for you? And the answer is no. Again, a funeral home will not act unless all of the next of kin agree to what's designated. And the personal representative and trustee might be appointed, but their role is really limited to management of the estate or the estate assets. A body is not really considered part of that, okay? So the role of an agent, when a healthcare agent steps into their duties, they're really the decision maker for you. They're your mouth when you can't talk for yourself, okay? Now, you can appoint whomever you'd like as your healthcare agent. This could be a spouse, it could be a trusted family member, it could be a friend, it could be a neighbor, could be a sibling. Now, I think that sometimes in my line of work, I often hear clients come in and they say, you know, I'm going to appoint my spouse, of course. I'm going to name that person, and then of course I'm going to have my firstborn child as the agent. There's not a lot of thought about, is this person willing and able to handle the role of serving as a healthcare agent? It could be that your spouse is the best person, and it could be that your firstborn child is, but have we thought about what their role and duties would be, and have we given some consideration, or are we just making a knee-jerk reaction because they're the next in line? Okay, so I want you to think through, is this person able to act for you? Would this person make decisions like you would? How does this person react in stressful situations? Because often making decisions about a loved one at end of life is very hard on your family and loved ones. And it could be if those people aren't accessible to you, or you don't feel like those individuals, family or friends, would be the best person for the job, there are some professionals that will act on your behalf. Generally, it's someone who's a professional fiduciary. They handle multiple clients, and they're designated as an agent, maybe as an attorney in fact or power of attorney for clients. And there are some nonprofit organizations who will act for you, including Lutheran Social Services of Minnesota. Okay? So the other thing is that this person should be willing and able to do the job, right? They should be willing and able to carry out your wishes.
Can you write down more than one?
Can you have more than one agent? Yes, you can.
I'm just saying if we both get in an accident,
Right. So typically, if you want your spouse designated as your primary, you definitely want a backup if your spouse is not able. And generally, I talk to clients a lot about this if they're of similar age too, because if one of you is incapacitated, the other might have a dementia diagnosis or may have health issues of their own, which makes it difficult for them to act on your behalf. So we want an alternate appointed, or maybe a co-agent if if it's necessary or beneficial. Mhm.
Okay, the two people I'm thinking of for an agent, I mean, they're my age. What if they pass? Should I have a third person then who is younger?
The question is kind of how far do you go, you know, because you might have someone or multiple people who are similar ages to you, and do you need someone of a younger generation or a younger option for a successor? And I think that, again, I don't mean to diminish it, but having one agent appointed with a backup, you're already leaps and bounds ahead of many people, right? But I think it is a good idea to think through, is there someone else that you can identify who'd be a good next in line, okay? Now, if that's a stumbling block for you to complete it, I would say we'd want to complete a form with who you know now, and then we can always give some more thought, do some diligence, and then amend or update, okay? Yes?
But people who don't live in the same jurisdiction, they live hours away.
Great question. So the question was related to, what if the person doesn't live in town or near you? Does that matter? Anymore? It doesn't matter a lot, okay? So I can tell you from my experience that people who are boots on the ground in a hospital have a lot to say, even if they're not a legal agent. That's just my experience, that providers are looking to who's there to try and get a sense of who has the authority to act and if they're comfortable with them moving forward in the direction they want. Now, quickly, if your provider has an instruction and the person who's there with you doesn't agree with them, then they're going to ask, hey, do you have a healthcare directive? Who's your agent? Because they want to make sure they're dealing with the person who's been appointed. And more and more providers are asking the questions on the front end and saying, do you have a directive before you even come in for a procedure or a surgery? Okay. But now people are very available by phone, by FaceTime. They can be utilized. I would recommend that it is somebody who can at least travel to you if you were in a prolonged state or condition, if you were hospitalized for a while, someone that's accessible at least by phone and who would be willing or able to come into town if necessary to provide a little bit more instructions and care options, okay?
Since I don't have any health directive, if I write just the basics, but I don't know everything, how much does it cost to have another one, you know?
So the question was related to cost of preparation of a document. And so if you can do your healthcare directive by yourself at no fee. So if you do that, there's no cost. If you have an attorney prepare it for you, there would be a cost to amend or change it. But you can download the forms by yourself. So it's something that as long as it's notarized and properly signed, you can do on your own. Yes?
If one thing, like, say, the manner of burial or something, just one thing needs to be changed, you have to have the whole thing rewritten.
So to amend a document, and we're going to get to that in a little bit, so I'm going to hold that question. I'm going to put a pin in it, but I promise to come back to it. I just want to make sure we get through all the materials. So what is a good agent? What does that mean to be a good agent? I think that it's somebody who can clearly understand your wishes, and that means typically that you've either had to do a good job in the document describing or making your wishes known, or you've had to be in communication with them about what those wishes are. And my preference is both, right? My preference is that you clearly outline what your wants or the things that you don't want are in the document, but you also have a talk with your loved one. And this also should be somebody who accepts your decisions. So I have some clients who say, I'm going to appoint my daughter, but man, she has a lot of opinions. She thinks that I shouldn't be cremated. She only believes in burial. Well, if you want cremation, is your daughter the best person then to carry out that designation for you? Okay. Someone who also accepts your wishes about end of life. If someone says, no, let's try everything. We want to make sure we've done every course of treatment. And you're saying, no, if I'm at the end of my life, I don't want everything attempted. I don't want to go through that process. So you want somebody who not only knows your wishes, but accepts them and is willing to carry them out. And then I think it's important for the person to be unafraid to ask questions, because often when we're working with medical providers, they're speaking a language we don't understand, right? If you asked me what the process of intubation was, I could give you very surface level understanding of it, right? I'm not a medical professional and I've never had intubation, so I don't know, right? So your loved one or your healthcare agent might have to ask them follow-up questions. What does that mean? What does this look like? What are the real chances of recovery if we try it and then withdraw it? Will this cause my loved one pain? These are things that they're going to have to assert themselves, and sometimes that's difficult when people in white coats are buzzing around you, right? Now, I think that they also need to be somewhat assertive to make sure your wishes are accepted by the professionals. So if there's a disagreement with the doctor, they need to be able to clearly communicate your wish and indicate whether or not you want to proceed in that way. And then I think it really helps to have somebody who's a good communicator with their other loved ones. So if you're designating one child, but you have multiple children, is this person going to be able to talk well with their siblings and just notify them about what's going on and why? I think that that's not necessary, but it's really helpful for the family. So I told you I'd mention a couple quick documents that might be helpful to you in addition to the healthcare directive. And primarily that's what we call a provider's order for life-sustaining treatment, or a POLST, P-O-L-S-T. A POLST and a healthcare directive really complement one another. They work well together. Typically, you need a POLST if you are terminally ill or medically fragile. If that doesn't apply to you, you may not need this document, okay? The purpose of this document is really to make clear what your end-of-life decisions are. It's a doctor's order, though. You're not drafting it. The doctor completes it with you. Now, they can complete it with your healthcare agent, too. If you were incapacitated, the agent could go through it. What's beneficial to having this document is that emergency medical responders can listen to it and follow it through. So generally, if you call 911, their job is to get you alive to the closest hospital. And then if your healthcare directive says, hey, we don't want to be resuscitated or receive any further treatment, then they're going to say, oh, at that point, let's make them as comfortable as possible. But in the interim, you've received care that you may not want. A POLST is a doctor's order, and that's the only thing that emergency medical responders can follow. And the default is that they have a standing medical order to treat you so you can be alive and go to the hospital. Okay. So the relationship with a POLST, and then I'll come to your question, is that the healthcare directive is meant to be there to designate a legal agent, communicate end-of-life wishes, and make those wishes known to your medical professionals and that agent. But it doesn't have the authority to be a doctor's order. Okay, so if we need, we would need a POLST if you, again, are terminally ill or medically fragile and say, under no circumstances do I ever want to be resuscitated or intubated. And I don't want any artificial nutrition or hydration ever. I don't want a feeding tube put in. I don't want an IV for hydration. I just want to pass away naturally and as quickly as possible. So typically we do that in cases where people are either have a diagnosis such as they might be already diagnosed as needing hospice care. That's typically when someone has a prognosis of 6 months or less to live. Or if they have, they're up in senior in age, right? And things like resuscitation could break ribs or do things that they just don't have an interest in. Yes, you first, sir.
Which doctor are we talking about? emergency ward doctor or your own personal doctor?
So a POLST is a standing doctor's order for any medical professional, but you can sit down with your primary care doctor to do it. So,
Your primary doctor changes, because lately, we've all been changing health.
right. So your primary doctors often change frequently, and you don't need to change your POLST every time your doctor changes. You don't. If you do it once, it will be a standing order until you change it or revoke it.
Even if you haven't seen that doctor for 12 years.
Even if you haven't seen the doctor for 12 years. Yep. Yes.
Is that similar to a do not resuscitate form? I'm referring, like, my father passed away in Wisconsin, and we did a do not resuscitate form.
Yes.
But we also got him a bracelet at some point, because if he had the emergency care people come to the home, they needed to see the document, or they needed to see the wrist thing.
The brace.
If not, they would treat him,
Okay.
resuscitate him.
Right, so I'm going to try and repeat what you just said. So the question was, is a POLST the same as a do not resuscitate order? And it's very similar to that. That's one of the components of a provider's order for life-sustaining treatment, is whether or not you do not want to be resuscitated under any circumstances, whether you may if chances of recovery are good, or whether you do want to be resuscitated. Typically, people only complete these if you do not, or if your feelings on that are really strong. There's an example here, and this is actually in your materials. This is what all POLST look like in Minnesota. And they're generally, I will come back to you, under colored paper, okay? And as far as finding these documents and where to leave them, in the 8-county metro area, all of the emergency medical responders are trained to look at your refrigerator to see if you have these documents. I know some of my clients roll their eyes at me and say, I don't want to look, I'd rather have pictures of my grandkids on the fridge. I don't want to look at my POLST document every day, but this is something that you should have on the fridge accessible. Now, there is, this file of life is something you can order online. There are magnets that are available, and I think some of the local, Roseville's fire department also hands out a similar packet with a magnet that you can put up there and fold your documents into. Yes.
Does the Roseville area senior program have multiple copies of the file of life?
The Roseville Area Senior Program has multiple files of life on staff. Yes.
Okay, so it's a document you make with your doctor?
It is a doctor's order. It's a document that the doctor must fill out. You can't fill it out without them because the doctor needs to sign it, not you.
Oh, okay.
So you have to do the POLST with your doctor.
All I gotta do is use that do not resuscitate, right?
This is the do not resuscitate form for Minnesota.
I still gotta do that with the do not resuscitate form with the doctor?
If you do not want to be resuscitated under any circumstances and you want emergency medical responders to follow that, then you need this POLST.
Oh.
Okay? So we've talked a little bit about having a conversation with your loved ones. And I call this the talk, okay? You have the talk with your children as they're coming into their adolescence, and now you're going to have the talk with your loved ones. Different topics, but equally as important. So the talk is really a conversation about what your wishes are and even who you've designated as your agent, sometimes the why you've designated that person. I think there are lots of ways to begin this conversation, but it's a difficult one sometimes to have. And I point out some examples of tools that you can use. The first being a picture of Brittany Meinard, and Brittany made national news a few years ago now because she was, I think, a 20-something or 30-something with terminal brain cancer. And she had to make some choices about whether or not she wanted treatment, and in fact, whether or not she wanted to pursue aid in dying measures, so to speed up her dying process or make it a little bit more comfortable for herself. And so that was a case that was nationally discussed on morning television, evening television, magazines. People were starting to have a conversation about Brittany's choices and her end of life. And I put that on there because sometimes we need something external other than us to start this conversation. We might need things that happen in the media. I know when we talked last time I was here, we spoke about Barbara Bush recently and her decision when she decided to pursue hospice measures instead of continuing treatment. There are things that are happening and getting public attention all the time, and sometimes that might be a tool for you to sit down with a loved one or start the conversation. There's also another tool that's available online, and it's a really great resource. It's free, called the Conversation Project. And the Conversation Project also helps you with some conversation starters or some questions to engage yourself and your agent about these topics. And then kind of a more participatory, fun option as well is the Go Wish cards, which is a deck of cards that's meant to be dealt out, and you sit down with your loved ones at a table, and you kind of sort the cards by your values, your personal values in order of importance. So there's a card that, for example, focuses on money related to care. And some of my clients say, I don't want my kids to spend $1 of my money on long-term care. If I was needing nursing home, take me out back, right? My dad has said the same thing to me multiple times, right? I tell him I can't, that's illegal, right? So the Go Wish, though, for him, he highly prioritized the monetary cost of care. And that was something that was a big concern to him and weighed heavily on him. So that was the monetary value was a big component to his plan. Other clients, you might have heard me talk about this, but I've had a client say that if I can enjoy a bowl of ice cream every night, keep me going, right? That's his favorite thing to do at the end of the day, is sit down with his favorite program and a bowl of ice cream. If he can't do that, life isn't worth living, okay? So for him, enjoyment of the things he loved weighed really heavily. That was not a cost decision. That was a pure joy decision, right? So people think differently about these topics, and sometimes we need something to give us some perspective about what those wishes may be.
Where can you get the Go Wish?
The Go Wish card game is available online. There is a cost to it. I believe it ends up being about $10 a deck. If you find friends in the audience who also want it, you get discounts for bulk orders. So the other thing that the components of the talk should be a communication of your wishes and values and clarify what you mean. So a lot of my clients tell me, I don't want heroic measures, right? They say, I don't want any heroic measures. If I'm at the end of life, I don't do anything heroic. What does heroic mean to you, right? When is life no longer worth living for you? What does a good death look like to you? And that's not often something we talk about, as dying is a taboo topic for many of us. But what would a good end of life look like for you? What does that mean? And then the benefits to having this talk is really diminishing an agent's anxiety. And sometimes they just really like to know, oh gosh, they've done this, they've thought about this. I'm not going to be on the hook to figure this all out on my own or sort through my feelings on this. There's no right way to have the talk, so you don't need to feel confined to a certain protocol for it. It can be what feels right for you and your family. I've had clients say, last year instead of going around the table and talking about what we're thankful for at Thanksgiving, we talked about what we wanted our end of life to look like. That's incredible. That's not something that my family did at Thanksgiving, but it is something that could be a venue where you could sit down and communicate this. There's not necessarily, or it doesn't necessarily need to happen all at once. It could be over time, but I do think it's important to have. and not to ignore. And as we talked about, we can use someone else's experience. So often when it comes to dying and end of life and care, we have loved ones who have gone through this, or people, family members, neighbors who have had a health crisis, and you've seen what has happened to them, and you may or may not like it. That might spark an idea for you about what you want, and you can use that situation to help communicate to your loved ones your wishes. So you can use the news, you can use these worksheets, you can use letters or video recordings, you can blame your attorney. We're an easy scapegoat if you say, my attorney said that they couldn't finish this plan until I talked to you, so we're going to have to sit down and have this conversation. Whatever it takes to start that conversation. You might be met with some resistance. So I'm going to warn you that I have had clients who have tried to have this conversation with their loved ones, and they've gotten a child who says, I just can't talk about this right now. Or there's nothing we need to discuss. It's not going to happen. It's in God's hands. And if you're met with that resistance from the person that you've appointed, I want you to think about whether that's the person to serve as your agent. Now, it might be that this person's just reactive and they need a minute to process and think through, but your agent is going to be the person whose job it is to carry out your wishes. So let's make them known. If they're not even willing to engage with you in a dialogue, then we might need to consider, is that the best person for the job? Now, there are ways you can turn the conversation if it's going that way. Be firm and straightforward. We're all going to die. I haven't met one of us who hasn't yet. Still waiting, right? Maybe with artificial medicine and intelligence, we might be going for a long time. But right now, everyone on this planet that I know of is going to pass at some point. We're all mortal. And point out the consequences of not having it. If we don't do this now, you're not going to know when a crisis emerges what to do, or where to find the documents, or who is the decision maker. We don't want you to have to end up in court, or you to be fighting with your siblings during an already stressful time. And really, you could ask someone to be your spokesperson for you. So you might have the conversation with an agent, but you might not be ready to have it with all of your children or loved ones. Maybe empower them to communicate with your loved ones for you, okay? Have a family meeting on your behalf. So, who should hold copies of these documents? You need a copy. Your medical professionals need a copy. Your healthcare agent should have a copy. Now, you could also give it out to immediate family members or close family or friends, and if you live in an assisted living or skilled nursing home, that facility should also have a copy. Okay? Now, the nice thing about healthcare directives are copies are just as good as originals. Okay, so if you sign one, you can make multiple copies and disseminate them to the people you wish to.
What if it's been revised? Can you find it old?
Yeah, so the question was, well, what if it's been revised and you find it old? And this kind of goes to a question that was earlier, how do you make updates and revisions? And I'm going to cover that in just a second. So where do you store documents? Where should you store these originals? In a safe but accessible place. So often I have clients tell me, Brenna, I keep all my original documents in a safe deposit box. Lots of groans in the audience. Some of you might have had an experience trying to access the safe deposit box. It's not easy, right? It's only available during bankers' hours. It's only available if you are the owner of a box and you have the keys to access it. So a safe deposit box should not be your primary storage space for your advanced care directive. You should make sure, some people, I generally recommend that people have a fireproof box at home and notify their loved ones where the documents are. So if your fireproof box is in your closet of the guest room, You make sure the next time your agent's in your house, you say, here's where it's stored. Here's what you need. Here's how you would open it if something happened. Why don't you try it? Okay? If it's a safe with a lock or a key, make sure that they have the combination, right? We want to make this as easy as possible for people. If you give one to your doctor, they can scan it into your electronic medical record, so it's available throughout multiple healthcare systems. I found, even though I have mine scanned on file with my providers and they share information, every time I come in, they say, do you have a healthcare directive? I say, yes, look at your file. But, it's part of their protocol, their intake form now. You can acknowledge that you have a healthcare directive on your driver's license. So the next time you go in, they'll ask when you get an updated ID, and you can note there that you have a directive. It doesn't say what it says or the contents, but at least it notifies the world that it exists.
Is this a change?
Is this a change? I don't know how long it's been in place, but it's been at least 5 years that it's been in place that you could do this. And some faith communities, churches, synagogues might store documents, healthcare directives. I think that that's only a good place to store it if your loved ones or your agent knows that that's where you keep it. And some attorneys might store a copy on file or the original on file. But again, an attorney's office that's only open certain hours is not the best place to be the only location for the documents, just like the bank. I'm going to turn it over to Deborah, but I want to let you know some other resources in your materials. I listed out some people that you might want to assemble on your care team. Not everyone will need all of these people, but generally it's good for you to have people who are familiar with what happens at end of life. There's so much to navigate through when you're dealing with long-term care or end of life, and so I've indicated some people who might be included as part of your team. And then I want you to review these documents really frequently. Multiple people asked, well, what if I review the document and I want to change it? So typically the best way to change a directive is to execute a new one. Now, if you only have a small tweak to the directive, you could amend it or add a paragraph to it, but you're going to have to execute it in the same way you did the original, which means either in front of a notary or 2 witnesses, okay? The hard thing is sometimes people revise and don't tell the former individuals holding the documents that there's been changes. So it is important to communicate if you've made changes to your documents to your agent or the appointed people. Sometimes it's important to have an external date that helps remind you. Typically, I tell my clients to use your tax filing date, right, as the time to think through updating or looking at this document. You don't need to meet with an attorney every year. You just need to pull these off the shelf, blow off the dust, turn the page and say, does this still resonate with me? Does it still make sense based on my current condition, maybe my prognosis, what's going on with my loved ones? And then I gave you some tips for how to get organized, how to assemble what I call a one-stop shop. So if something happens to you, where people can locate documents.
So that HIPAA form, it's my understanding that you have to fill it out in 3 months and 6 months, the bridge to amendment.
So
Just fill it out and have it on file.
So the question is related to a HIPAA release, and often medical professionals or medical providers have their own internal rules. It's not based on federal law or a time frame for length of validity. If you have it in your healthcare directive, authorization or release, that's good for your agent whenever. But if you were not incapacitated and you just wanted to say, hey, doctor, if something happens to me, you can also call my child, then the doctor might require you to fill out HIPAA releases somewhat regularly. And I'll hold your other question and we can talk later tonight. I want to make sure that you hear from Deborah, okay? So thanks for your time, and I'll be available at the end as well. Okay.
Thank you, Brenna. It's always a pleasure to listen to Brenna. She is full of information and great ideas. And you can't hear me. Now can you hear me? Much better. All right. Not very loud? Okay, so I have 6 kids, so I'll put my mom voice on. All right, so thank you for being with us tonight. I want to bring a totally different perspective. My first task as a healthcare agent was to put my late husband on life support. He was diagnosed with terminal cancer. We were in the emergency room, and he was admitted to the hospital. He wasn't getting better. And the conversation was he's headed toward respiratory failure with pneumonia. It was my responsibility, so I thought, to go ahead and put him on the ventilator. In hindsight, that was his decision. He was still lucid. This was back in 2011, and things have gotten a lot tighter since then. The last act as a healthcare agent that I did was to remove life support and allow him to die a natural death. Even though we had all the conversations, I knew exactly what he wanted. I did as he asked. I suffered. I ended up with an undiagnosed case of PTSD, and I didn't know it for 2 years. And I ended up quitting my job because I couldn't function. And I ended up saying, okay, we need to talk about this, not from the legalese perspective, not from the medical perspective, but from the human perspective. So as you go through this, you have pictures. Because in the moment of chaos, everything that you've said is probably going to be forgotten. So what I try to do is to create something that is simple. You can start the conversations with it, you can pick it up, you can use it anytime. I didn't give you the whole presentation. I want you to just sit back and kind of watch it and let it flow over you. For those of you who are here with a loved one and a partner who's your agent, think about who's your alternate. And have you had the same conversations with your alternate agents? Because if you can't speak and your partner can't speak, your agent, your alternate is going to. I worry most about what I'll call the cross-generational. If you have an adult child listed as your alternate, and your primary is someone of your generation, our generation, it is much easier to understand what it's like to live in your body at the same generation. Your kids will think of you as parents. I want mom, dad to live forever. Dad's my hero, okay? We need to find a way to bring the kids along with the story. So what you'll hear tonight is processes, pictures, showing you kind of just stepping through what happens, and suggestions for you to jumpstart conversations. It's going to be based on my experiences and my observations as I've heard stories, as I've spoken about this. What I cannot do, I cannot give you legal advice. I cannot give you medical advice. I cannot give you financial advice. I am not a physician. I am not a nurse. I am not an attorney. And I am not a financial advisor. But I have experienced all of that. And so I'm not telling you what to make, what decisions to make. But I want to show you what it's like for your agent, whether it's a loved one who is of your generation or it is a child. And I may use the terms healthcare agent, agent, surrogate interchangeably because certain studies will use different things. Advanced care plan, you might see ACP, it'll be referring to advanced care plan. HCD will refer to your healthcare directive. So how I do this, on the left, you'll have pictures. On the right, I'll give an explanation. And so we'll start. The advanced care planning that Brenna talked about, we think about it. We think about it a really long time. We look at the paper, looks like a snake. We pick it up, we put it down, we shove it away, we put stuff over it. We overthink it. But eventually, we do it. We document it. And then we file it someplace. Maybe we give it to the right people. Maybe we don't. We are so happy we got it done. So it is the advanced care plan, the healthcare directive, where we attempt to define our quality of life. We attempt, or we make it legal. Brenna talked about getting it notarized or having it witnessed by 2 people. She talked about making it accessible, all of the places where you file it, and then we are done with it. So I come at it from a different perspective. Your healthcare directive does a great job in saying who. I say owner, Brenna said principal. Primary agents, alternate agents. Says what they can do. What your healthcare directive doesn't do is it doesn't explain exactly how to honor your choices. Everything you've listed in there, if you're not able to speak, somebody else is having to figure out what you meant. And in the throes of a medical event, I can pretty much guarantee you there's going to be a moment of panic. Their first reaction is going to be fear-based. I'm not ready for you to go. You need them to get past the first reaction and get to the second reaction, which is representing you. It doesn't say exactly when and how to start to figure out how to start a treatment, not start a treatment, continue, stop, or wait and see. And I try to remind people that not starting a treatment sometimes is easier than removing a treatment. So removing life support is hard. Not starting it might be the appropriate action. It may not be the appropriate action. That's something that has to be discerned. Wait and see. Do I have to make this decision right this minute? Can I wait 24 hours and let it sit and figure it out? And I ask the question here, do you teach your healthcare directive? Because otherwise it's like writing a book, tossing it over the wall at the student, and never going on and explaining it. I like to think that we should mentor our healthcare agents, whoever that may be, especially if they're the cross-generational child. And the reason I say that is I ask the question, is it working? 50% of decisions for older adults will be made by a surrogate, an agent. 95% of the decisions made in the ICU are made by a healthcare agent or surrogate. However, 78% of the time the decisions are based on the patient's well-being. If I were mom, I would. If I were dad, I want dad too, as opposed to 22% of the surrogates making decisions based on the patient's choices. The last time we talked to mom, she said. The last time we talked to dad, he said. And this is without regard to whether or not a healthcare directive exists. So we have to find a way to make your healthcare directive compelling, easy to understand, so the kids or your agent will make your decisions. 22%. It helps, by the way, if you do have a directive. But we are the problem. There was a study that's listed on the bottom in 2017, I think it was 2015 or 2017, and it talked about the barriers to goals of care conversation. And the top 6 barriers are that the agent, the patient, and the family members don't understand, accept, or agree with the patient's medical status. And here's the top 18 listed. Family members' difficulty accepting a loved one's poor prognosis. Family members' difficulty understanding the limitations and complications of life-sustaining therapies. Lack of agreement amongst family members about goals of care. I have 6 kids. We have a blended family. He had 3, I had 1, we had 2. You think those 6 kids are going to agree on anything? Absolutely not. 4, 5, and 6 are about the patient. Also, same thing, not understanding life support. So this is where I get into the pictures. So let's talk about this for a moment. In any medical event, there is a patient, one patient, only one patient. There is a healthcare agent. There may be 1 or more. I have 3. Mine is any one of the 3 can make the decision, whoever is with me. And time sensitive, when it's no longer urgent, then it goes to the number 5 daughter and then the number 6. So there's healthcare agents. I make the distinction between a healthcare agent and a caregiver, and I'll show you why in a minute. Bear with me. Loved ones, there's a boatload of them. Medical professionals, there may be a boatload of them too. So the patient, that's the one with the medical event. The healthcare agent, that's the one that you made on call. Okay, so if you think about a doctor being on call, they know everything that they need to do. It's a matter of getting the call, but they're knowledgeable. The caregiver is the person who helps with the personal care and needs if needed. Loved ones, patients, family, and friends, and the medical professionals. Everybody has an opinion in a medical event, but the only opinion that matters is yours as the patient. So let's look at this. When the patient can speak, patient makes the decision, okay? When you can't speak, the healthcare agent slides over and they make your decisions based on the guidance that you've given them in either conversations or in your directive. So here's an example. My late husband's name was Bill. He was diagnosed again with terminal cancer in the emergency room. We went from terminal to normal to terminal in 4 hours. And then 2.5 years later, he got pneumonia. But if we look at it, Bill was the patient. We had 6 adult children, their spouses, siblings, 11, he had 11 siblings, I had 4. Spouses, parents, grandparents, great-grandchildren, family, and friends. And I was a wife, so I was in the loved ones too. I was also his caregiver. I was also his healthcare agent. So let's look at how this goes. All right, the alternate was the number 5 daughter I mentioned. What's my primary role? I'm going to give you an example, and you can say it, you can think it. Bill has indigestion. Am I wife? Am I caregiver? Am I agent? I have a pink hat here. Pink hat. Am I wife, caregiver, agent? Okay. I'm wife. He can walk to the cabinet and he can get his own Tums. Okay. Test number 2. He has a fever. It's mild. He doesn't feel good. He's going to go lay down. He needs the aspirin. Will I bring it to him? Am I wife, caregiver, agent? Caregiver. You got it. Okay. Test number 3. Fever, severe, going to the ER. What am I? Caregiver, agent? I'm hearing both. Okay? Caregiver, he's lucid, he can talk. Okay? I'm driving, he can talk. caregiver. Now he's admitted to the ICU. He's in a medically induced coma. Now what am I? Now I'm the agent. You think I knew that? It took me 6 days to shift out of these two hats and remember that the minute he went unconscious, medically induced or not, the minute he couldn't speak, I'm agent. I didn't make the shift. I'm making decisions as his wife. I'm answering the doctor's orders. Should we put him on the ventilator? That was his to answer. 5 minutes wouldn't have made a difference. He could have said yes. He could have said no. I said, yes, honey, I've got this. I've got you. Okay? You have another year to go on your cancer prognosis. So imagine your alternate agent having to remember which role they are. So my brother, I pick on him all the time. But think about him for a moment. He's got multiple roles. He's all of those things for his wife. Our mother had Alzheimer's. He was all of those things for my mother with Alzheimer's. And oh, by the way, he's one of those people that Brenna talked about where he didn't know he was her agent until she was already in dementia. He didn't want the responsibility. We would have had to go to court to get it changed. He took one for the team, and he stayed on as her agent, and he struggled. He has twin daughters. And then he has his own cancer diagnosis. So imagine his world trying to keep track of his wife who is in her 60s, his mother who's in her 90s, and his daughters who are in their 30s. All different decisions. If there was a car crash and a leg was mangled, you know, mom, she's in a wheelchair. She might not need her leg. Wife, touch and go. Daughters, boy, he's going to try to keep them functioning as best he can. So again, back to the pictures. Let's look at your health care directive in perspective. You have your baseline health. This is when Brenna said this is the best time to write it. Write your health care directive when you're not in the middle of a medical event. You have a medical event, it becomes a disruption to your life, and you'd figure out what's changed. Can I get back to normal? Can I get back to my baseline health? Or do we have a new normal? In our case, with terminal cancer, we got a new normal in 4 hours. And so again, the best time to write your healthcare directive is when you are not in the middle of it. You can write it in the middle of an event, but you're focused right there. You're not thinking big picture, you're thinking tactical. What am I going to do in the next 4 hours? So again, disruption. So when you start with the medical event, everything gets out of context again because you're focused right now at what's in front of you. We talked earlier about your agents making fear-based decisions. You're making fear-based decisions. I'm not ready for this. I'm not critical thinking. I use a term called confirmation bias, and this is something all of us have to be aware of and think about. So I'm sitting here listening to the medical professionals, and I'm going, and Bill's going to be okay, right? Now, if that's not a leading question, I don't know what is. And I heard everything they talked about through that filter. Bill's going to get better. We're going to put Bill on the ventilator to give him time to heal. I heard give him time, and I heard give him he will heal. Okay? Role confusion. Again, it took me 6 days into an intensive care stay, meeting with the doctors every day, sometimes 2 and 3 times a day. It wasn't until day 6 when I realized he was on life support. because it was one treatment at a time. We need to put him on the ventilator. He needs blood pressure support. Yes, yes. He needs dialysis. Yes. His heart's starting to get irregular. It's out of rhythm. He needs to be defibbed. I've seen it on TV. Works for me. Yes. So I had the role confusion. I heard everything, and I made my decisions, not his decisions. So starting at the baseline is the best place. So the process of a medical event, what I'd like you to think about is a medical event starts, you get a diagnosis, you get a prognosis. You know, it wasn't until Bill got sick that I realized there was a difference in those terms, and they are totally different. You get suggested treatment options. You needed to make a decision. You need to implement the decision, you need to monitor the decision, and then you repeat it. Okay, so the diagnosis, the cause of the symptoms, the prognosis is the timeline for recovery. It is a prediction, not a promise. Okay, they can't promise you anything in a prognosis. Suggested treatment options. Again, I remind people that no treatment and wait and see are always options. Decision, you got to choose an option. And then you implement it and you take the steps to start, not start, continue, stop, or wait. And you monitor it. So what happens if you have multiple things going on, like high cholesterol? You have a wound. I did that on Easter. We'll talk about that in a bit. High blood pressure, cancer, pneumonia. All of those things each have their own cycle. And when you can't talk, your agent is going to have to be savvy enough to work through this. And many times, each of those conditions have a different physician or a different clinic. So now you're dealing with all sorts of people in all sorts of places. So what's your priority? We talked a little bit, I think Brenna touched on cost. I label these as the triple constraints, right? Every decision that you make will be a balance of these three, and it is a fluid balancing act. What's your quality of life? What is it that you want to be able to do? Quantity, time, how many days, how many months, weeks, years, cost, financial. You have to think about force ranking these. What's your number one priority? What's your second number, or your number two, and your number three? So is it cost, quality, quantity? That comes up with one treatment option. Or quality of life versus cost versus number of days? Or is it the number of days versus the quality of life versus cost? You are asking your agent to make that determination if you can't talk. If you can't make the decision, have you counseled your agent? So for me, when I talk with my kids, it's like, okay, you know, I have to say cost consideration is my number one. Is the procedure covered or not covered by insurance or Medicare? I finally turned 65, so now I have to throw Medicare in there. All right, is it in network or out of network? What's my maximum out of pocket for the year? Because your agent will make medical treatment decisions that will have a financial impact on you. Quality, I must be able to do, fill in the blank of what's important to you. I would really like to be able to, or it's okay if I can't ride my motorcycle. We'll talk about that too. Quantity, you can always say try it for a period of time, or it's okay if I'm in bed for a long period of time as long as I can talk. It's all about you. What do you want? I put this up because too often we only think of ourselves as a physical body. I want you to consider an emotional, spiritual, and mental aspect. And what I mean by that is the physical. We know this. The emotional. How do I interact with people? This becomes important. My mother died from Alzheimer's. She had no idea who I was the last 5 years of her life. I was that woman that she kept trying to throw out of the church pew because she had no clue why I was sitting in her pew. The mental, this is where we hold our beliefs. This is how we process, how we think. Spiritual, how do we connect with something? You know, chat is a great one. It's a community event. How do we connect with community? So here's how that picture looks differently with an Alzheimer's diagnosis. You have a physical body, but your mental, emotional, and spiritual, your ability to connect with anyone shrinks. I use Stephen Hawking as an example. He was in a wheelchair, but he had a huge mental capacity, okay? I admire him, but man, I don't want that. He was amazing. Okay, so now I threw in a refrigerator, a stove, a microwave, and a car. And you're going, what does that have to do with my healthcare directive? I have seen more people, as I've started talking about this, who spend more thought on whether the refrigerator is side by side or the freezer's on the top or the bottom, and should I get the matching microwave and stove, than on what medical treatments I want. Do I want a four-wheel drive car? Do I want a truck? Do I want black? Do I want red? When you get in the medical office, all of your decision-making rational goes out the window. And I have seen rational adults turn into, yep. And so the doctor's recommended treatment becomes their default choice because they haven't taken the time to step back and say, my baseline health is this. How does that treatment get me back? Here, I talk with my hands. So let's talk about the conversations. Again, I have 6 kids now, and this is what I call the kid effect over time. I was a kid. I had parents. I grew up. I became a parent. I have kids. Somehow my kids now think they're my parents. Remember my finger? Okay, so I have a cut on my finger. I had ants in my bathroom and it was annoying me, so I got out the ant poison and I had a pocket knife with me and I opened the jar with a sharp pocket knife. Easter morning, I'm in the urgent care center and I have 5 stitches in my hand. So I was amused. My kids, on the other hand, pretty much said, do I have to be your dad now and tell you how stupid that was? That was a quote, by the way. So there are implications to what I'm saying, though. When I was 16, I hit a tree with a car. And my philosophy was, don't tell mom and dad because they'll take the car keys away. So in January, this past January, I had the tailgate down in my truck. I hit a tree. My kids live out of state, and I'm thinking, I'm not going to tell them. They'll try to take my keys away. So this is a humorous example, but a very real fear we have. At what point do our kids start saying, you can't do that. You can't live independent. My kids told me they wanted me in a nursing home after my husband died, so I did what any kid would do, and I did the exact opposite. I moved into the woods, and I have a house heated by wood, and I bought a chainsaw and a log splitter. I also got my motorcycle license. So if that didn't give them pause, it's like, how did we not know that was on your bucket list? Huh. And I explained to them, I'm at the age, do it now or do it never. They want me safe, I want to live. So we've developed this informal code of sharing information with our kids, right? they don't ask, I'm not telling. I answer only the question they ask. If they don't ask the right question, oh well. If they do ask the right question and I don't want to answer it, I've learned how to deflect, deny, distort, or distract. When all else fails, I can always say, do you know what your sister did last week? Works great. Yeah, so basically we don't share information with the kids. And if we have them listed as an agent, we need to share information. So in your handouts, you have some of this. And this age, we need to talk about age. What I find is visuals cut through everything. What decade am I in? I was talking with a palliative care doctor. Her patient, her client patient, is in her 60s. The woman's mother was in her 90s. And the patient, the 60-year-old daughter, just couldn't grasp the fact that mom was in her 90s. And I like to use the timeline to show where we are on the timeline. I watched a family whose mother was 85 years old with congestive heart failure, diagnosed with terminal cancer, and the kids are going, Mom, you can fight this. Terminal cancer, and the kids are going, you can fight this. So what I'm trying to do here is to cut through that denial of mom and dad are going to live forever. And I'll give you some examples so that this will make sense a little bit later. But have you shared your age? Have you talked about when your parents, if they're living, how old are they? If they died, how old were they when they died? Siblings? And do you have a sense of how long you'd like to live? And I'll come back to that. That's a tough question that people are uncomfortable with, but I'll show you how to make it work for you. Have you aligned everyone? Brenna talked about, have you talked to everyone? The hardest part is when you have an agent who's out of state, and again, using my difference with a caregiver who lives next door, and the caregiver not understanding the difference between being a caregiver and making the decisions that mom would make. Activity scale. Have you talked with your children about how active you are? What do you do to keep active? How important is it to you to stay active? What do you do for fun? How many underlying conditions do you have? How many chronic conditions do you have? How many terminal conditions? This little guy is in here. I call it PAT because it stands for patient. Could be Pat, anyway, it's Pat the patient. And I color code it because the major difference I find is when you're talking to the medical professionals, they start talking about medical systems and they start giving you data. And I just want to boil it down to something that I can understand. I understand the major organs, and if you think of a stoplight, red, yellow, green, I'm not taking any meds to support a particular organ, right? I'm not taking any meds to support my heart, okay? I'm not taking any meds at all, so everything's green. Now, if I have high blood pressure and I'm taking meds for my high blood pressure, I'm taking meds, so that's yellow. If I have a hole in my heart and the meds aren't working, I need surgery. It's red until they can bring it back. But that's a simple way to cut through denial and confirmation bias. How many prescriptions are you taking? If you're taking 0, that's one statement. If you're taking more than 10, that gives your family another piece of information. Oh, where do you get them filled? Over the counter, Prilosec is a big one. Used to be a prescription drug, now it's over the counter, and a lot of drugs are now over the counter. How many are you taking? And have you shared that? Vitamins, herbs. What's your pain scale? You know, I would say everyone in this room is over the age of 29. Maybe a couple of you are 30, a couple times over. So at our age, it's not like living in our bodies when we had them at 29. So Bill and I were quite, I was complicit in this. He didn't want the kids to know how badly he was hurting. He was a soldier, so every time the kids would come visit, he'd soldier up at the door. He hid how painful it was to be in his body. Every step he took hurt. Was the pain or is it temporary or permanent? His neuropathy was permanent. It was not recoverable. Breakthrough pain, is it bad and then gets worse? How anxious are you? What keeps you up at night? What concerns do you have? So we've gone through quite a bit. I've thrown quite a bit at you. So let's put it together. Let's take all of it and give you an example. Here's me. I'm 65. The reason I asked the question about the parents, my goal is to live until I'm 120. I got my motorcycle, I'm going for a ride. My parents died at 93. At 65, I'm a little bit halfway through my life, or 2/3 if I look at my genetics. I'm moderately active. I have no underlying conditions. I'm healthy. I don't take any drugs. I have a wait and see that I'm looking at right now, but I'm not taking the drug. I'm going to see if I can fix it with diet and exercise. I do take over the counter. And I'm in no pain, and I'm not anxious unless I'm standing in front of you all speaking. Everything's green. My quality, cost, quantity, number one, always number one. What is it going to cost? And I'm willing, and again, I'm not telling you what to decide. I'm just using this as an example. I'm willing to accept a lesser quality of life if it's in network. It's just the fact of where we're at. And I'm not willing to live days without quality. I'm willing to take a smaller, again, I'm willing to see my world kind of collapse, shrink might be a better word, as long as it's balanced. Bill, when he died in 2011, he was also 67 when he died. But on his side of the family, his mother's side, all of the men died at 65, so he was tickled that he made it beyond the average life expectancy in his family. But he talked about that for the last 10 years of his life. So he was anxious about that. His 65th birthday was a big deal because he didn't think he'd make it. He was starting to slip into inactive. He walked into the hospital the last 10 days of his life. He walked in. He only had pneumonia, so I thought. He was overweight, had high blood pressure, and he was terminally ill. He was taking, because of the cancer, he was taking more than 10 drugs. He was taking probably 10 over-the-counter drugs. He was in severe pain. He was moderately anxious, and that was starting to slide over. Someone along the way had told him he would most likely die in his sleep. He didn't want to die in his bed. So he started not being able to sleep. When he died, he had sepsis. He had all the organs started shutting down. Pneumonia slid into sepsis. And he couldn't make it back because he was weakened from the cancer. His, number one, cost, number two, quality, number three, flat out did not want to be in a nursing home. His physical was declining. My mom died in 2016, 93. In a bed, inactive. Underlying conditions, high blood pressure, chronic conditions, and what I didn't know then that I know now, Alzheimer's is considered terminal. 5 to 10 prescriptions, as long as she could swallow, and when she couldn't swallow, then that stopped, obviously. She was starting to slide into severe pain. She couldn't communicate, so she resorted to biting the staff. Because the thing with Alzheimer's is she
Your
was,
voice is fading. Could you repeat that?
yep, so she was biting the staff because she couldn't talk. So when you have Alzheimer's, you're 90 going on 16, then you're 91 going on 8, and then you're 92 going on 4, and then you're 93 going on 2. So your mental starts going backwards. She couldn't talk, so she did what any 2-year-old would do. She bit people. And hers ended up being quantity, because by the time my brother realized he was the agent, it was too late to ask her. He struggled with that, I mentioned. He said, I don't know if I am doing this to her because I don't want her to live this way. Am I inflicting my decisions on her, or am I actually making the decisions she would want if I could talk to her?
What do you mean by quantity?
Days.
Oh.
Days.
Length of time.
Length of time. And in her case, her physical body was shrinking, but the emotional, mental, and spiritual side was pretty much non-existent. So, to your healthcare agent, I would say these words. Just because modern medicine can, doesn't mean modern medicine should. Your first reaction may be fear-based. Get to your second reaction. Do the work. Please remember, this is not about you. This is about me, the patient, my choices. Do the best you can. Surround yourself with a trusted team. Brenna had it right, and I absolutely agree. Find that trusted team. And this is from your healthcare agent. This is from your kids talking to you. Saying you'll know, not helpful. Don't make me guess what you want. Talk to me. Really talk to me. I had one gentleman that I sat with in Bemidji, and he said, I talk to my daughter every day for 30 minutes while we drive to work. But I realize now it's social conversation. It is not decisional conversation. At least once, have a decisional conversation. Making your decisions, again, this is from your agent to you. Making your decisions is not natural. It's not going to come naturally to me. Give me examples of what you want and what you don't want. Talk to the rest of the family so they know what you want. I don't want to be judged for doing too little or too much. Help me understand what you want. Even knowing that, it will be hard. Thank you.